Donna, I've missed you, and everybody, welcome to the Med List. I'm Kevin, and this is Donna. And today, Donna, I've had an onboarding kind of experience with a company. I'm really excited to talk more about someday soon. But onboarding is interesting. Like, there's so many new things that come at you, and things that you just don't know about which questions to ask and how to position those questions. And when you and I were kind of talking about this episode, I was like, wow, what a perfect kind of combination here, not to use even more analysis or comparison. But when you start with a new inhaler, most people, when they're used to taking medications, it's pill form, right? Or maybe even liquid form that they're kind of accustomed to. When we start getting into inhalers and how to utilize those inhalers, that adds a level of complexity. And then when to time those inhalers or when to appropriately use them adds another level of complexity. And now there's changing guidelines that are even adding complexity to clinicians that thought they knew when these inhalers should be used and how they should be leveraged, but they don't, because it's now changed and kind of shifted our kind of mentality. For you as a clinician, Donna, and as a patient, what have you kind of thought about the inhaler world over these last, let's say, 5 years?
Yeah, just a lot of changes, not only with what you're supposed to use when, but inhalers themselves have combined products now too. So it's not just one medicine, one inhaler. There's multiple medications in an inhaler. So that might change things up a little bit. So we got to be very vigilant about what we're communicating to patients and caregivers, or what patients and caregivers are understanding as to what their inhalers are that they're getting.
Oh, entirely. Yeah. And I'm really excited that we get to bring our guest Tim on that has some expertise. He even ran across, we got to thank him. He put his cardio in today, ran across an entire basement for us to grab props just so you guys could be even further educated in the space. So I want to thank him and bring him on board for an intro from Donna.
Absolutely. So thank you so much. Welcome, Tim. We're so happy to have you with us. So today we have Dr. Timothy Hudd. He's a professor of pharmacy practice at MCPHS University in Boston. So just a different campus than me, so homegrown in Boston area. In 20 plus years of experience on the faculty. He is a certified asthma specialist and has held leadership roles, including past chair of the National Asthma Educators Certification Board and current chair of the Certified Asthma Specialist Examination Committee for the National Board for Respiratory Care. He also serves on the board of directors for the Association of Asthma Educators and is a national expert for AstraZeneca. And he's also served as the advisor of U.S. Precision Programs and Precepts Clinical Ambulatory Care Students at Tufts Merrimack Family Medicine in Massachusetts. So welcome, Tim. Thank you for being here.
Thanks for having me. Great to be here, Kevin, and thank you.
Yeah, so I mean, your CV, if you will, your short bio speaks volumes of really your concentration in inhalers and asthma education. And gosh knows we need it, right? There's so many little innuendos that we need to know in regards to exactly how to use an inhaler. And it's not really as easy as we think. So I would love to hear more about you and your journey into educating people and providers on asthma and inhalers.
Sure. Right. So I think, I first became interested in asthma management because I have a personal connection. I myself have exercise-induced bronchospasm. And so back in high school and college, when I ran track and played soccer, I struggled with that a bit and had to learn very quickly how to cope in order to be competitive. And unfortunately, back in the early 90s, I almost lost my mom to an asthma exacerbation. Thankfully, she's alive and well and okay, but, guidelines were in their infancy and there was a lot of mismanagement of patients who had asthma. And so she actually, for a brief period of time, arrested in the ambulance on the way to the hospital. And thankfully, the EMTs were able to save her. They performed an emergency intubation and saved her. So that was quite traumatic. And so after that event, I said, you know what, that's never going to happen again. And so I, like a lot of folks that I serve on various committees and boards with who have also an area of interest of asthma, they have that personal connection. So I think that usually is part of the driving force behind the interest and desire to stay.
Wow,
amazing.
that's fantastic.
Quite a story.
Yeah.
I'm glad she's okay. Gosh.
You gotta say amen to mama's being okay. That's always the most
Yeah.
important part of life.
No,
Make
it's,
sure they're okay.
Absolutely.
With that, Tim, you got to tell me kind of this piece. You said you had the personal component and with mom on that side and asthma in particular. When you're then going in from manifesting some of these ideas of what asthma was, how it kind of impacted you, and then recognizing the treatments overall and kind of what was in space. What did you encounter were some of the obstacles and difficulty from going from those guideline days to today of getting us kind of up to date on how to use inhalers, how to keep people safe and avoid those situations?
Yeah, I think if you think back to the late 80s, early 90s, right, it was, some folks who've been practicing for a while might remember theophylline, right, which is an oral medication that can use to help, open up the airways, and parabuterol, which is Maxair, which is no longer available. So a little, not quite as selective as albuterol, which is, been sort of, I think, the long-standing rescue therapy, although things are starting to change even in that regard. But for the last 50 years or so. So those were the go-to agents. And it wasn't really until the late 90s or, mid 90s that folks began to realize that this is a disease of airway inflammation. And we need to address that inflammation because it's really the inflammation that is driving that bronchoconstriction. If you think about that early phase response, right, when somebody comes in contact with a trigger, some of the early phase mediators that are released are histamine and leukotrienes, and these are very potent bronchoconstrictors. So essentially, when you're getting that constriction, those bands of smooth muscle around the airways that are clamping down and narrowing the airway lumen where air passes through, it's making it hard for patients to breathe. And so historically, folks are reaching for maybe a short-acting beta agonist, agents like albuterol, because it helps them, right? They feel better. But if you don't get to that root of the issue, which is that inflammation, that's generally where things will continue to progress, particularly if they're exposed to whatever they're sensitive to, and they'll flare. And then they end up on mega doses of a steroid. So, it's really, I think a vicious cycle, and we've become better at making sure that folks get the right medications that they deserve and having proper maintenance therapies. But, there's still work that needs to be done because we know about 50% of all patients with asthma will experience at least one flare every year, which is really, I think, an interesting statistic to kind of think about.
I've got to ask this side, Don, and I know that, all three of us with our pharmacy backgrounds, like getting to the root of the problem is something, usually we're not talking about with inhalers in general. We're trying to say we've encountered some kind of inflammatory process, COPD related exacerbation, depending on the disease state we're looking at. What have you seen over the years, Tim, that's really helped us to better guide patients on recognizing when they may encounter some of these situations where they could have some additional inflammatory response and could need an inhaler or could do some things to avoid it?
I think that just raising awareness around best practices with, clinicians who can spend time with patients and educate them on what good control looks like, right? I mean, we have certified asthma specialists now, AECs. And so that's an opportunity not only for pharmacists, but also other disciplines to become, trained to really help patients better understand their disease. So I think that coupled with evolving guidelines that are used by clinicians, and there are a number of CME opportunities and CE opportunities for clinicians to make sure that they're up on the latest and greatest. And there's been an evolving understanding of the pathophysiology, right? We now have biologics over the last 10 years or so, rapid growth in that space with folks who have more severe asthma. Rewind about 10, 15 years ago, a lot of times patients were on, prednisone, maybe chronically if they had severe asthma. Now we have better tools in the shed. So, there's opportunities there to have very selective agents to help, attenuate that inflammation in different ways without exposing patients to systemic corticosteroids, which really are, can raise havoc, right? A lot of adverse effects.
Absolutely. So Tim, I think some of the major changes that we have seen, and we've mentioned it a couple of times in this discussion already, is the guidelines have changed. And I think there's probably two areas that I find are really interesting and very different, and not necessarily followed by everybody, maybe depending upon the number of years someone has had asthma for, and maybe changes haven't been made. But one is that albuterol really isn't necessarily the rescue inhaler of use now, and that guideline has changed dramatically. And then the other thing that I think is very different with the guidelines now is we talk about de-escalation too. So at a certain point, if your asthma's been in control, is it possible to reduce a little bit? So could you comment on both of those, and just talk about the big changes and what's, maybe the science behind it, and do you really see it working? Do you see it happening, that people are actually having these changes to their regimens?
Yeah, so I think this is a really good question. If we look at, management of asthma, right, there's really two key guideline documents that folks will follow. You have the National Asthma Education Prevention Program, right, or NEEPP, has a guideline document. There was a bit of a focus update back in 2020. Wasn't considered a major overhaul, but it brought changes to how we escalate and de-escalate medications, right? And then we also have the Global Initiative for Asthma, or GINA report, which has been updated annually. And this is really, I think, becoming the go-to document for clinicians because it's updated a little bit more frequently. It also includes more information about biologics, which was really not the focus of the 2020 NEEPP update. Now, in both of these documents, at least especially GINA since 2019, they've all together said we no longer support albuterol alone for asthma rescue. And the reason being is because asthma is a disease of chronic airway inflammation. And so it's really important to address the underlying driver of that bronchoconstriction, which is the inflammation in the first place. And so they offer this track approach. And so there are two tracks. You have this track 1 versus track 2. In track 1, they advocate for ICS formoterol combination products. And so, we talk about formoterol. Formoterol is a long-acting bronchodilator. It's kind of like a long-acting albuterol. So it lasts up to about 12 hours. But it can be used as a rescue option because the onset of action is about 5 to 15 minutes. So it opens up the airways relatively quickly while delivering the steroid. And so some patients who might be on ICS formoterol for their maintenance, it can be incredibly convenient for them to just take an extra inhalation or two of that medication when they experience breakthrough symptoms. And that helps, not only address the bronchoconstriction immediately, but also will get to the root of the issue, which is that rising inflammation that is causing those breakthrough symptoms in the first place. So that's the new paradigm of asthma rescue. Now, track 2 would be if, let's say, patient is on albuterol and that's their rescue of choice. What GINA says is it should also be followed by a dose of an inhaled corticosteroid. Now, we talk about escalation, de-escalation, and complexity of regimens, right? And that can be incredibly cumbersome for some. And there is a product that has budesonide and albuterol. It's an ICS SABA that is also available for those patients. And so that is an option. If you're looking at that track 2 approach and you don't want to use multiple inhalers. But like anything, there's options. There are some folks who maybe prefer 2 separate inhalers for whatever reason, right? And so if that's the instance, I think the take-home point is make sure that you're not using albuterol alone for asthma rescue. They really should have that steroid on board, especially at the time where they get that rise in inflammation.
Yeah, absolutely. So curious, why? So there's many different long-acting beta agonists, but only formoterol is the only one that is mentioned in GINA guidelines to be used as a rescue and combined with any ICS or inhaled corticosteroid. So curious, what is the reason that formoterol is the only one that is in the guidelines to be used as a rescue?
That's an excellent question. So the other, long-acting beta agonist that's available as a sort of a standalone, if you will, is salmeterol, brand name Cerebin. And so salmeterol also has a 12-hour duration of activity, but the onset is around 30 minutes or longer. So it doesn't really make well for somebody who might need to be opened up more quickly. Remember, formoterol, 5 to 15 minutes, very similar to albuterol. Right now, there are other beta agonists that are available: olodaterol, volanerol. These are long-acting, 24-hour duration. You can imagine, the more of that patients would use, it may not be best suited for somebody who might need multiple inhalations in a relatively short period of time, and they just haven't been studied, frankly. So at the present time, it would be ICS formoterol. The ICS that's been most studied is budesonide and formoterol. There's been some studies involving beclomethasone and formoterol, but that is not a product that's available in the US. So at the present time, if you're considering an ICS formoterol based off-label, by the way, because it's primarily been studied in patients who are late adolescence, early or into adulthood. It was studied overseas and a different device. It was actually studied in a completely different device, a dry powdered device. So ICS formoterol is off-label, but that is the most studied ICS. Budesonide formoterol is the most studied ICS formoterol-based combination product at the present time. So if you look at the track one approach, that's sort of what they're referring to.
Great.
And I know, Donna, you also asked me a little bit about de-escalation, right? And so that's another really good question is if you're following any EPP recommendations or if you're following GINA recommendations. In both of those documents, they generally use the 90 days or 3 months as the the threshold to say if somebody's been well controlled, meaning they haven't needed their rescue inhaler, they're heading maybe into a season where they don't typically flare and all is well, then you can consider stepping down their therapy. And so that is something that is consistent between both GINA and the NEPP recommendations. And so then the bigger question then becomes, well, how do we step down therapy? How do we do it safely? How do folks know when to step down? And to be honest with you, at least from what I've seen in primary care, it doesn't usually happen. And I think part of the reason behind that is sometimes these patients are not coming in every 3 months. So sometimes it's every 6 months. Sometimes it's every year, right? And so when you think about that follow-up and what it might look like, if it happens on an annual basis, especially if patients have other problems, a lot of times the pulm, if it's not actively flaring, it gets pushed to the side, and then the focus becomes whatever the other issues that patient might be having. So I will say that unfortunately, even though that is something that is consistent in both of these documents, right, it doesn't always happen.
Do you think there's a fear too of, when I'm ever with my students and we're talking about issues with breathing, asthma, COPD, we always talk about the anxiety. That's also a part of that. And if you don't have an issue, can you imagine what it would be like to not be able to breathe or breathe well, and how anxiety provoking that is? So if you're telling someone, oh, you might not need that, and they're like, whoa, did you see what I was 3 months ago or 6 months ago? Like, what do you mean I don't need this kind of thing? Because I think we are programmed that it's a chronic disease. You need to keep taking it.
Mm-hmm.
But I'm assuming that there are some really good positive outcomes that if somebody doesn't need to take something like an inhaler, maybe it does allow for, I don't know, a little less money out of their pocket for one thing, but also if we have people, and I know inhaled corticosteroids aren't terribly systematically absorbed, but I always think about people who are prone to osteoporosis over time, and if you have a young, small Caucasian woman, for example, or Asian woman who needs an inhaler, and they're on that threshold and they have many other different types of issues or or factors that could eventually cause osteoporosis for them, I go, whoa, that might be really wonderful for that person to not have that always on board. Do you agree with something like that? Is that a correct thought process?
I think the thought process of using the least amount of medication possible to control disease is really important, right? I think, let's say somebody is on a highest strength, Advair 500/50. Do they need 500 micrograms, or can we cut that down to 250? Would be a reasonable discussion in somebody who maybe has been well controlled for at least 3 months. We can consider reducing that steroid, usually by 25 to 50%. And then see how things go. I know Gina Report does have a section where they go through some of the suggested, how to de-escalate somebody from one strength or one regimen down to another. But on any of those strategies, for the most part, depending on where they're starting at, it's very difficult to say we're going to just take a break from this and heal it altogether, right? Because again, knowing that this is a disease of airway inflammation and knowing that triggers are quite unpredictable, right? Flu season, sometimes that comes out of the blue. Next thing you know, now they need a systemic corticosteroid. So what I'm much more concerned about is if somebody isn't controlling that inflammation with micrograms, right, which is delivered directly to the lung, it does have some systemic absorption, but not nearly to the same extent as, a prednisone burst where they're getting 40, 50 milligrams in a sitting. Remember, there's 1,000 micrograms equals 1 milligram. So, when you put in that perspective, you need a lot of doses of an inhaled steroid to equal a burst. So I would much rather head off that systemic corticosteroid burst, which, by the way, is really what's been linked to, some of the complications that you're referring to in terms of changes in bone mineral density and some of those types of adverse reactions. So I think, it really depends on that starting point. Now, if somebody's on a low dose steroid, and there are periods of the year where maybe they don't need that on board and they can go over to maybe an ICS formoterol as needed. Maybe they use a product like Arisupra on an as needed basis, because knowing that if they have breakthrough symptoms, they're going to get steroid on demand. There is data in that regard. And so that could be an option for some folks, but it really, again, depends on what their regimen looks like at the start as we go down.
Sure. Great.
And I would also add, you'd probably want to make sure that patient is a good perceiver of their symptoms, right? So a lot of times patients don't necessarily understand fully what good control means. It's not normal to require using albuterol on a daily basis, right? So these are things too that are opportunities for education. And so just, having folks maybe assess their control with validated questionnaires could be an option, too, just to give some objectivity with, all right, here you're at. We're going to look at maybe reducing that steroid dose. Maybe we're going to change that regimen up, and then we'll reassess your symptom and risk burden with other, follow-up questionnaire in a few weeks, depending on the situation.
Sure.
Yeah, I feel like oftentimes we get into the conundrum in medicine that if the lights are off, then it'll be dark and someone will fall and break a hip, right? So we always leave the lights on, no matter what. And then that puts a drain on additional systems and other problems, related to it. So my question, I guess, understanding that, hey, if we can reduce things, as you're pointing to, Tim, substantially reduce them down when it comes to exposure to inhaled corticosteroids versus someone has an exacerbation, they're put on prednisone, not just the burst components, the osteoporosis that Tim and Donna were talking about, but other things that they would mention is, how do you taper off the prednisone? All the other withdrawal symptoms related to it, the problematic components with just going to that drug in general, great to be able to avoid. That all said, how do we start monitoring better, Tim? Like, how do we start monitoring our symptoms, right? How do we start tracking where we're sitting if we can avoid some of those other drug utilizations so folks can see, here's where I'm sitting with my overall asthma control?
Yeah. So I think that, it starts with making sure that patients have an asthma action plan. So I know that if you look at, the American Lung Association, the Asthma and Allergy Network have really good free online resources that clinicians can use to help patients, develop an asthma action plan. And so what an asthma action plan essentially is just a plan to have in place in case somebody is experiencing a decline in their symptoms, and what do they do about it, and how do they recognize it? So asthma action plans, are generally underutilized in everyday practice. I think less than 25% of all patients with asthma actually receive one. And so to your point, Kevin, that's another really good opportunity is to, is sit down with a patient and help them with an asthma action plan, which can be symptom based, it can be peak flow based, it can be both in either scenario. And so that would be, one strategy to help.
Beautiful. Yeah, super helpful. So you mentioned that statistic, which I absolutely love, that is a very low percentage that have an asthma action plan. And with that, automating an asthma action plan so it's easy and accessible and retrievable, all of those components kind of bring in, hey, how can we use technology and other things to be able to pull into the fray? The same thing I've seen, kind of in the adherence space, Tim, when it comes to a few different companies that are leveraging like actual utilizations of what's called an actuation to everybody out there. You press down an inhaler and it sends out a puff, so to speak. And you can track those things, which is great. So now the clinicians can be tapped into how often is this patient using those individual doses, and that patient can see how often am I using my short acting or my ICS plus SABA, or how often am I using my other inhalers, and get a better idea on that. I think that's important. I'd love to have that piece of the conversation, but I would be remiss if the run across the basement we didn't talk about with Tim is here's another statistic that I think is wild. And Tim, you can give me the ones you've seen, because I've seen it anywhere from 8% to 50% of individuals using inhalers do not use them appropriately. Give us some more insights on that.
I have seen that statistic as well. And so, when you look at, I think when we think inhalers, right, we think meter dose inhaler. And when I say meter dose inhaler, we're referring to those inhalers that have a canister, right? So these are your canister based options. And inside that canister, you have not only the medication, but you have a propellant called hydrofluoroalkane, or HFA. So if you see HFA in the name, it's a meter dose inhaler. And so as you had mentioned, Kevin, I think one of the challenges with meter dose inhalers is the fact that it requires some level of coordination for patients when they basically actuate or push down on that canister. They should be inhaling at the same time. And it's a slow inhalation. What I oftentimes will find in practice is patients get nervous that they're going to miss the dose. And so they take a really quick puff and coat the back of their throat. And so that would be incorrect technique. And so in our practice, we have something called the in-check dial, which is a device that we use to essentially we can dial up the resistance on the various inhalers that the patient may have. And then there's an indicator on the side, and we have them take an inhalation as they would through their inhaler to see if they're inhaling at the right speed and tempo. And so that's another really good, I think, teaching tool that you can use with patients after you demonstrate, and you have them demonstrate back, which it's a technique called the teach back technique, but then take it one step further, use the in-check dial, and just make sure they're inhaling at that right speed and tempo.
Super helpful.
Hey, Tim, do you have that? That's one type of inhaler with that in-check kind of device. Do you have that for other types of inhalers, like an Ellipta inhaler?
Yeah, so the in-check, as newer devices become available, the in-check, the folks who developed the in-check dial also evolves with those devices. So I know another setting on it is another device that is very commonly used in practice. And I have a whole host. There's so many different devices, but just to demo maybe this one and one other. But the discus is something that I think is commonly prescribed, because when you survey prescribing clinicians, usually it's the meter dose inhaler, and for whatever reason, the discus, probably because these are two devices that have been available for the longest period of time. This is what they're familiar with, right? So a lot of prescribing comes down to muscle memory, right? So folks just, they prescribe what they're familiar with. And so this one is a dry powdered inhaler. So, for the most part, you have your meter dose inhaler, you have your dry powdered inhalers, and there's a whole host of options with DPIs. And so this is the discus, and the way this works is you just, you put your thumb in this little thumb grip and you push it over to the side. And I tell my students, make sure you hold it in this horizontal position, like a hamburger or a veggie burger or whatever what you go to is. And then there's a lever on the side. And when you push that over to the side, you hear that click. It opens up a little foiled blister pack inside there, or a pouch of powder. And so because it's a powder, pretty much the instructions when you look at how to use the devices are pretty similar. You don't want to blow into it. You don't want to get it wet. You don't want to shake it. You want to exhale away. And that's with any device. And I think the main reason for the exhalation prior to that inhalation is to make sure you empty the lungs so you can take that slow and steady inhalation in to get that powder aerosolized. Now, the challenge with the dry powder inhalers is, unlike the meter dose inhaler, it doesn't require as much coordination, but it does require that patient to be able to inhale with a little bit more of a kind of a strong, steady inhalation to get that powder aerosolized, because there's no propellant to get the powder out and into the lungs. And so some patients have trouble with that. And so again, that's where that tailoring comes into play, using something like the InCheck to make sure that they're able to inhale with enough drive to get that aerosolized would be important.
Yeah. So Tim, if someone has trouble with that strength to inhale,
yep.
Is there, and maybe some coordination issues? I'm thinking of older adults being specialized in geriatrics, right? Do you think that the Respimat type of inhalers, though it is tough to twist those, do you think that is easier for people to take because of the breathing that needs to occur, or do you have one that you prefer over the others, depending upon someone's level of being able to have a strong inhalation?
Yeah, so it really depends, because even within the dry powdered inhalers, some devices will have a higher level of resistance for them to inhale through to get that powder out, right, than others. But I think if we're looking at a meter dose inhaler and there's a difficult time coordinating the actuation inhalation, you can use something called a valve holding chamber. And the valve holding chamber, the drawback is it's an extra piece they then have to attach to it, right? But they actually hold the dose for a few seconds. Some will come with a mask, so that can be incredibly helpful if let's say patient doesn't want to use a nebulizer. Or a nebulized option, or maybe the product that they're looking for is not available in that particular dosage form, then perhaps that's a remedy to the meter dose inhaler. When we look at nebulized solutions and we consider Respimat device, folks that don't have the ability to maybe get that powder aerosolized for whatever reason, then those could be options. The Respimat, though, doesn't have a steroid containing product. So you're limited to what's in that portfolio, right? So Respimat has long-acting bronchodilator as a standalone, a long-acting beta agonist. It also has a combination of an antimuscarinic and a beta agonist. So you really have to look at, what it is you're trying to, have on board as part of their regimen. And the other piece, when we think about asthma, the only, product that's available in the Respimat that's approved for asthma is Spiriva. It's the low strength, and it shouldn't be used alone. That's another really important, I think, point is we're not using long-acting bronchodilators, whether it be a long-acting beta agonist or a long-acting antimuscarinic like Spiriva alone. Those should always be combined with something that's going to also address that airway inflammation.
But that's only for asthma.
Only for asthma, right? For COPD, if we're looking at, because most of the, when we look at the Respimat portfolio, right, the approval really is COPD. And so in that instance, right, there's just no steroid-containing option, which for some, not all, but for some may need that.
So Tim, do you mind if we shift gears a little bit to COPD? I think this is a perfect time to do that. And so when we're looking at asthma, we're starting off with, it's really important that we have the ICS on board, no matter which track you're doing. Right. If you have a long-acting beta agonist or a short-acting beta agonist, you really need to have that inhaled corticosteroid on board. It's different with COPD. And so let's talk a little bit about what those guidelines tell us, if you can share that with us, and then when later on the ICS might be added in.
Okay, sure. So when we shift gears and consider COPD, I think really what's become the go-to document in terms of guidelines, if you will, is the GOLD report. So and they don't like to call it a guideline document. They call it a strategy document. But it's, I still refer to it as a guideline. I think most clinicians do. So the GOLD report was updated last November. So it's the 2025 GOLD report's available. It's updated every November. I attend that conference every single year. It's down in Philadelphia, Temple Health. And so they do an excellent job with it. A lot of the guideline authors attend that conference as well, and they talk a little bit about the rationale as to some of the updates and how they came to be. So it's really, to me, very interesting. So when we consider some of the recommendations in the GOLD report, really the cornerstone of therapy in general is making sure that folks have a long-acting bronchodilator on board. And this whole concept of 2 bronchodilators are better than 1. So we used to, in some instances, for folks that maybe are a little bit more symptomatic, use maybe a single class option like a long-acting antimuscarinic, an agent like Spiriva, right? Or a long-acting beta agonist, as a standalone. But a few years back, they said, what we're looking at COPD and these folks are having difficulty moving air. We find that you get better bronchodilation when you combine agents from 2 separate classes that cause bronchodilation. So they go right to LAMA-LABA, and that's really become the backbone of therapy for most patients with COPD. Yeah. And so I think that's a big difference when you consider, COPD, if you're comparing that to recommendations we talked about with asthma.
I think too, I'm sorry, Kevin, I keep interrupting you.
Go right ahead.
So what I find, and when we're shifting people, right, from the short acting products that they can feel, that they don't necessarily feel these long acting products, and then they abandon them. So some of the meds that are combined, or sometimes they're not combined, and they're using multiple inhalers, at least that was the case a few years back. And people would just say like, oh, I can't feel that Spiriva, so therefore it's not really working. But I always try to share how it's helping to dry up the secretions that are involved with COPD, that is part of the reason why we use that product. And so when they come in the hospital and you're all congested because you stopped using your Spiriva, then that's going to be a problem. So in just understanding the reason why behind these products too, I think is really important. So are you finding that combined products, for example, are really more mainstay of treatment for people, whether it's asthma or COPD, in that we're not really seeing a lot of these single products being used as often?
Yeah. So I think when you consider the GOLD approach to COPD, right, you have this triad, if you will, where you have these COPD risk groups. You have group A, group B, and group E for exacerbations. These are the folks that tend to have, 2 flares of moderate severity per year, or if they're hospitalized due to a COPD flare, right? You'd be in that group E category. Now, when we consider risk group A, you can use short-acting bronchodilator as a standalone, an agent like an albuterol or maybe an Atrovent, right? But when we move over to that group B, what separates group B versus A is really their symptom burden. So folks that have this risk group B COPD tend to have a higher symptom burden. And so in those instances, what they've shown is that having that combination product to help open up the airways is going to not only help relieve symptoms more efficiently and effectively, but also can help increase lung function, can help increase or reduce risk of exacerbations, right? And so that becomes the backbone when you consider group B, as well as folks who are in that risk group E, those who might be flaring frequently and who have certainly usually a heavier symptom burden as well. So this is, COPD can be, a very progressive disease. These symptoms, as you know, are persistent, right? So sometimes when patients are using these bronchodilators, whether they be a standalone or in combination, they may not necessarily, especially if they continue whatever the insult is to their lungs. Like, for example, I know cigarette smoke is a significant risk factor for many. If you continue to smoke and you're on an inhaler, over time, you're still losing lung function because you haven't haven't taken care of the original issue and the injury to the lung, right? So that could be one reason. So I usually will look at, is there an opportunity for smoking cessation? And then all patients with COPD should have a short-acting option just for breakthrough symptoms. Because, let's face it, I mean, if folks are being maintained on a dual bronchodilator and then they walk up a flight of stairs, they may get short of breath. So in that instance, they may need something to reach for on demand. And so they should have a short-acting as well.
You both bring up perfect points. And Donna, you didn't interrupt you. You just literally took like it right out of my brain. You asked the exact same question there. So that was perfect. So
we were a long time together.
Exactly. Simpatico. But along those lines, Tim, the one thing I'm curious on is, when we see some blood markers that are showing additional potential issues with inflammation, right? And we start adding on the ICS or the inhaled corticosteroid component to the COPD individuals. A fascinating thing in my mind kind of clicks there of that exact burden. I had a patient, I know I've shared this on another show before, Donna, but I had a patient that he had a diary, Tim, and he had COPD advanced enough that it was very difficult for him to get from sitting in the living room to his bathroom. That was about 20 steps away, right? And so as that was progressing, sitting on the counter in front of him was a journal, and he would write down his inhaler, his long-acting inhaler, and right next to it, he would write the words voodoo, because he didn't notice anything. Like he thought it was just witchcraft, related to it, because I'm not getting any benefit from this. And now the story really changes to this. Even though we know this is going to be beneficial, reduce hospitalizations, et cetera, are we missing something as clinicians when we're not talking or putting the emphasis points on what you just mentioned there, Tim, with having that bronchodilator or an ICS, available for those individuals? If two things, I guess, on that point. Tim mentioned using it after going up a step of stairs. I've talked to patients previously about, if you're going to encounter a situation where there's either one, going to be an inflammatory response, or two, you're going to exert yourself further pre-dosing. Do we need to do a better job of that? And what do the guidelines say about that utilization of the standard long-term therapy?
Yeah, no, I think that's a good point. Is a lot of times if you're encountering a scenario where you're typically getting short of breath, the strategy would obviously be best if you can kind of preemptively give maybe that boost ahead of time. So I think, at least pharmacologically, that makes sense. We know these agents, they take a little time for onset, right? So why not head it off? When it comes to opportunities and with COPD, one of the medications that tends to be overprescribed is that inhaled corticosteroid component, right? And you mentioned, there are biomarkers or things that we can look at. And so within the GOLD committee, one of the biomarkers that they've really committed to is a white blood cell called an eosinophil. And so eosinophils are, basically they can be used as a predictive marker for ICS response. So the higher the eosinophil level, the more likely that patient will get a beneficial response from the steroid component, right? But the other caveat to that is not only do they need to have that elevated eosinophils, but they should have frequent flares or severe flares as well. So you look at really those two in tandem, because if somebody's well controlled on a LAMA-LABA, they haven't really flared at all, they don't have a history of asthma, that might be fine for them, right? So you really want to interpret these biomarkers, if you will, in the context of the patient when you're making those decisions, because we know that, especially in the instance of COPD where folks tend to be older, they have a lot of other medications on board. They may be a little bit more sensitive to, having that inhaled corticosteroid as part of a regimen. And so, there is a slight increased risk of pneumonia, especially in folks that have, poorer lung function. And so, that is a consideration when we think about cost benefit of adding that steroid, right? But if they're flaring frequently and they have high eosinophils, eosinophil levels of, generally initially we look at, above 300, 350 on follow-up. The threshold is usually around 150, maybe 100, depending if they're having frequent exacerbations. It will lower that threshold a bit. But when we look at sort of the separation, it's usually just after about 100 cells per microliter, if you look at an absolute eosinophil count, where you see that benefit of having that steroid on board. But just, again, it's a very specific subset of patients with COPD, unlike asthma, right? I think that that's kind of a key point with COPD. So look for that. I mean, that if they don't need that steroid on board, then why have it there?
So helpful. And the last one I had, Donna, was really along one thing that, we talk about deprescribing quite a bit. Surprise, surprise, right, Tim? But I think with drug optimization, the one thing we don't get into very often is drug optimizing PRNs or as needed medications, right? And for some things like a rescue inhaler, the general thought process is, you just use it when you need it. But there's other components to that. One is the monitoring we talked about previously of how often you're using that and making sure that within that guideline or the action plan that you have in place, that tracking is something you're working with your clinician and trying to reduce. The other part is avoiding the need for it. So Tim, can you educate, when it comes to inhaler usage in general, if we're trying to reduce either, you mentioned before, the milligrams of a given component within an inhaler or using so much of a PRN, or rescue kind of medication, what's some advice to our patients and clinicians on how to avoid the usage of that or decrease usage?
So I just want to make sure I understand correctly. So we're looking at maybe the rescue regimen and overutilization of maybe a standalone albuterol or bronchodilator?
You got it. Yep.
Okay.
Either one of those, or if we're talking about that de-escalation that you mentioned previously of reducing the ICS component, right, or the corticosteroid component of a drug, what are the things that we can do in terms of physical activity, avoiding certain situations and or called disturbance, I guess, within the lung, all those other triggers, that we can avoid, plus the exercise and nutrition components. What things have you seen to be able to reduce those levels of use?
Yeah, no, I think, if we're considering asthma, right, we'll take asthma first because it can get confusing, right? If we're talking asthma, COPD, they are different, distinct, approaches and disease states. So, with asthma, generally, if a patient is using their rescue inhaler, there's something called the Baylor rule of two, right? So if somebody's using their rescue inhaler more than twice a week, if they're filling more than 2 canisters of 200 count albuterol and actually using it, not just one at home and one in school, right? If they're actually using 2 full canisters per year, or if they're being awakened more than twice a month due to asthma symptoms, that is usually, a sign that maybe that asthma maintenance regimen needs a little attention, right? Now, that could mean a lot of different things. Not necessarily we need to increase the regimen, right? And what they're taking. Maybe they're not taking it at all. Maybe they're taking it, but not taking it correctly, right? So I think that sometimes it goes back to basics, right? Let's look at why we're going off track here. Why are we overutilizing that rescue? Are we using it correctly? Are we using it at all? Something maybe in the environment's changed. Did you just, maybe come back for some travel and where you were, right? Environment changed and now we're back and things might settle in, right? So I think that, with asthma, that is certainly a consideration, which makes that whole ICS SABA all more attractive, right? If you can have that steroid as part of the rescue, they're going to get that built-in increase in steroid, but very transiently, very focused manner, only on demand when they need it, rather than overutilizing their albuterol. Now, if they're using, let's say, that on a consistent basis, right? Even though they're getting that steroid, in those instances, I would probably look at the maintenance regimen and say, okay, well, why do we need to use that ICS SABA or that ICS formoterol on a daily basis for breakthrough symptoms? We're having, too much of a frequency here, right? So in that instance, we may want to consider. So I think that, generally, those are my thoughts with regard to asthma. When it comes to COPD is a very difficult condition, right? This is a condition that is progressive. Very seldomly do we take things away. Can it be done? Yes. I think that, like anything, it tends to be progressive, particularly with continued exposures, right? And so it's making sure that what they're using for regimen is actually working for them and that they can use it, right? We also want to make sure in COPD and asthma, for that matter, that we're controlling or able to reduce things that will cause these diseases to flare, right? And so immunizations are really, I think, a really important area that pharmacists have been able to make, great progress in, right? So for both of these conditions, I always make sure that patients are getting an annual flu shot because when we think about exacerbations, they're often triggered by infection, right? So we now have the RSV vaccine for folks particularly those over the age of 60, right, who have certain health conditions like asthma, like COPD, other comorbidities like diabetes. You also have the pneumococcal vaccine, right? So folks should have the conjugated pneumococcal vaccine. That's another really important, vaccine to protect against invasive pneumococcal disease as well as pneumonia. And so I think, when I look at a regimen, how do we make sure that we help mitigate potential risk factors for future exacerbations, right? If they're smoking or vaping, which is a whole other set of challenges, right? That we address those issues as well.
Excellent. Thank you.
Tim, a couple of things. I'm glad you brought up smoking and vaping, because I think that is something that even that could change in somebody, right? Someone's younger, has asthma, things are in control, and then, maybe they hit high school or, college or something, and vaping looks kind of interesting now. So, is always having to consider those changes, right? That somebody might have made that change versus even just a schedule change for inhalers. The other thing I want to talk about is other changes or other things that could cause exacerbations. For example, I want to talk about some meds that people could be taking just briefly. If we could just, what are some of the other items that could be on people's medication lists that might cause exacerbations or maybe would interact with the efficacy of inhalers, for example? Are there some standards that you're always looking for when you're talking with patients or making certain that they're not on certain medications?
Yeah, I think one of the big offenders is certainly like beta blockers, for example. If we're giving a beta agonist to help open up the airways and relax those smooth muscle fibers, then we have beta blockers that can counteract that effect. Specifically, more of those beta blockers that are not cardioselective, right? And especially if they're used in higher doses. So even cardioselective beta blockers, for that matter, in higher doses might start to lose some selectivity. And so we have to be mindful of if somebody were to maybe, have an increase in their beta blocker or a change in their regimen where it's been added, that would be something that, would be a consideration. Some patients with asthma will experience, having some difficulty tolerating an NSAID, right? And so if, let's say they have, an NSAID that now is introduced to the regimen, if they're noticing a change in their breathing, that would be another, medication that oftentimes will come up. So those are, at least a few medications that come to mind.
Yeah. The one thing that I've seen in the hospital is patients will be on propranolol for anxiety, right? Because and then they have these breathing problems that also cause anxiety, and so that is one of the non-selective beta blockers. And like, timeout, we really got to change this. They really need a different type of anti-anxiety medication for sure. So just thinking that through and just being thoughtful with the meds that you're taking. So really anything new, I think, is really important to make certain it's not going to interfere with the inhalers. But yeah, I just think that that's such an important part, and just to make adjustments if necessary, and make certain that good products are being prescribed when necessary that don't cause further exacerbations. The one other point is, if you don't mind just going back just a little bit with the whole pneumonia side of things. So I know with COPD, if someone has a lot of exacerbations due to pneumonia, we try to reduce that ICS because it may be causing increased risk of pneumonia for folks because of the decreased immune response that it results in. So could you just talk a little bit about that? I'm finding that, if someone's in a hospital and they've been in the hospital for a few different times for pneumonia, it's really a hard sell for a hospitalist to say, hey, yeah, we should really reduce this ICS for somebody with COPD, for example. So could you just mention a little bit about that and what you know in regards to the importance of trying that potentially?
Yeah, I think, when you consider having the ICS as part of the regimen, right, it will go back to, does that patient maybe have a history of asthma that has over time remodeled and now kind of morphed into COPD? Do they have really high eosinophils? If that steroid really needs to be on board, then, of course, then looking at what they're receiving and making sure that they're on the lowest possible dose. Really the only when we think about option in if you're, I guess, practicing it consistently with GOLD document, right, is having a LAMA LABA ICS in combination. So one of the newer recommendations out of GOLD the last few iterations is if you're going to have that steroid as part of the regimen, have it as part of the triple, right? And so currently we have 2 inhalers that have an ICS, a LAMA and a LAMA, but only one at the present time is approved for COPD, right? And so using the lower strength, Trelegy, for example, is a potential option. And actually, I'm sorry, Breztri as well is an option in a meter dose inhaler. So, using the lowest concentrations of that, I mean, Trelegy is built in, it's the lowest strength available, compared to the 200 microgram strength. But maybe if they're on, fluticasone or an additional inhaled corticosteroid on the side, the question is that needed? Or are we better off maybe just using a shorter burst, which is the trend, is using maybe a, less than a 5-day burst just to get things under control, make sure that that's part of the regimen, make sure they're using it correctly, making sure that they have their pneumococcal vaccine, at least one conjugated dose if they're over the age of 60, for example, right? And then go on from there. So, but yeah, it's tricky. Because you don't want to deprive them of the steroid if they're a candidate for it, right? But I think it is valid to make sure that they are, in fact, a candidate.
Yeah.
So
that goes the whole. If they're not a candidate, it was certainly not. If they are a candidate, would we recommend it? But but just looking at that and saying, you know what, they might fare better if they might not be in the
lowest effective dose. Right.
Again.
Exactly.
For sure.
Yeah.
So,
what a great word to end on there, Tim. Tricky. I like that. I think that it's, in terms of a topic, that there are so many tricky, if this nuance kind of elements. And Tim really highlighted a few things for the audience that are getting an asthma action plan, focusing on the asthma component and realizing what the updated guidelines are recommending for overall utilization, trying to have that open communication with you and your clinician on not only am I taking this correctly? Am I using some of the tools in place to help me take it correctly? But also long-term, am I utilizing this in a way that's going to help me with my disease state and control it progressively? On the COPD side, really illuminating components, Tim, there on some of the changes overall to the regimens and just the combination standard that we're looking at for the most part, but also looking at a couple of factors that can say, here's what you can utilize for some rescue-ish or some activity components, within COPD to be able to help you with quality of life aspects, for you to be able to be more successful when taking on physical activities or going into new environments, whatever the case may be. So that's super helpful, Tim, all those elements that you kind of pulled into play. Any final words for our audience from the show today?
No, I think, again, everybody for dialing in, and I appreciate the opportunity to be here this evening. And there's certainly a lot of moving parts with both of these conditions. So I think, the fact that we're able to cover both asthma and COPD and all kinds of questions on top of that was a lot of fun. And we did that without any illustrations, right? Other than a couple of props that I ran across my basement from to get. So, thanks for bearing with me with that. But no, it's really great to have the opportunity to be here with you guys.
Awesome.
Thank you.
Awesome. Well, thank you so much, Tim. And to all the folks that tuned in, thank you guys so much for being here. We're on YouTube, LinkedIn, Facebook that you can grab us immediately, and some downloads will going to your streaming services as well here sometime soon. Any questions, let us know, and we'll see you next time on the Med List. Bye, everybody.